much for joining. Hello, everyone. Thank you so much for joining in our monthly lung cancer webinar. Today, we have the unique opportunity to have very esteemed colleagues presenting together, specifically around early stage non-small cell lung cancer. All the way from the East Coast, we have Dr. Patrick Forde, who is a professor of oncology at Johns Hopkins and has really led many of the pivotal studies, in fact, actually the first studies, looking at immune therapy in the neoadjuvant setting. And from UCSD, we have Dr. Joshua Boyes, who's really an amazing thoracic surgeon, who's really pushed our program forward in many ways around adoption of a neoadjuvant strategy for patients with early stage disease. So without further ado, we'll get started. And what we're going to first start with is just a quick presentation about the Checkmate 816, as well as the Aegean clinical trials that had recent data releases this year. And so, Dr. Forde, actually, if you want to proceed with that,
Perfect.
That would be great.
Yeah. Can you see my slides?
Yes.
Perfect. So I'll briefly run through things. There might be a little bit more slides than I plan to present, but I'll move quickly. So this was the Checkmate 816 trial, and this was initially reported last year and then published, and there's been an update on the 3-year outcomes this year. Just a reminder, this was a study of 3 cycles of neoadjuvant chemo plus or minus nivolumab for patients with stage 1B to 3A non-small cell lung cancer. It used the 7th edition, so it was predominantly what we would now say is stage 2 or 3A non-small cell lung cancer. And patients who had EGFR or ALK alterations were excluded. The key difference between this trial and the other studies we'll discuss, there was no adjuvant immunotherapy in this trial, so patients just got the preoperative treatment. And the primary endpoints were PCR and event-free survival. These were the demographics. You'll see most of these neoadjuvant trials, they skew a little bit towards stage 3 disease. So here there was 63% clinical stage 3A. This trial had a little bit more PD-L1 negative tumors than the other two. So here about 50% were PD-L1 positive, and about 45% negative, whereas in the other studies it's about 60-40 PD-L1 positive, PD-L1 negative. This was the disposition. So, 83% and 75% had definitive surgery. There was more chemo in the adjuvant setting given actually to the control arm, presumably because of not having as much of a pathologic response. Unusually enough, when you add a new drug, there wasn't any real kind of additional toxicity, which we could discern from adding nivolumab to chemotherapy in the preoperative phase. And the surgeries appeared to be comparable, if not somewhat better, actually, in the nivolumab plus chemo arm. And these were some of the immune-mediated adverse events. Nothing really significant there. Most of them actually a little bit lower in the Nivo arm. This was the first endpoint. PCR was increased from 2.2 to 24% with nivolumab plus chemo. And these were the 3-year data, which Hatim mentioned. These were presented at the European Lung Cancer Conference earlier this year, showing a sustained benefit at 3 years of about 14% for those patients who had Nivo plus chemo. This appeared to be kind of present for most patients, less so for stage 1B or 2 tumors, and less so for PD-L1 negative tumors. However, all of the bars are to the left of one, suggesting that the majority of patients derive benefit here. This was time to death or distant metastasis. This is seen as kind of an early surrogate of overall survival, again, favoring Nivo plus chemo. One interesting thing was we see kind of predominantly a reduction in distant recurrence. So you'll see here in the middle of the screen, in the control arm, the rates of distant recurrence were 22%. In the Nivo plus chemo arm, they were reduced down to 10%, whereas local regional recurrence is quite similar between the two arms. Again, one thing which the surgeons, and perhaps Dr. Boyes can comment on this, but the outcomes for the Nivo plus chemo arm overall were good. There was more minimally invasive surgeries in the Nevo plus chemo arm than in the chemo arm, and fewer pneumonectomies in the Nevo plus chemo arm compared to the chemo arm. This was just an indication of kind of this preoperative signature consisting of PD-L1 and 3 other inflammatory markers, suggesting that this might be a potential predictor of pathologic complete response, and also potentially event-free survival. It appears to have prognostic impact for Nevo plus chemo, but not for chemo. So this is something we're going to explore further. And ctDNA also is a possible predictive marker for benefit, although this was underpowered. About 1 in 4 patients were evaluable for ctDNA, and those patients who cleared ctDNA during preoperative treatment appeared to do better. The clearest indicator, though, was PCR. Those patients who had a PCR do quite a lot better than those who don't, about 90% 2-year event-free survival versus about 50% in the non-PCR group. And overall survival is trending towards benefit and not significant as yet, despite that p-value. So it's been approved worldwide in many jurisdictions, including the US at this point. These are the other trials, 2 of which I'll briefly run through now. Aegean, which Dr. Husain mentioned, was presented at AACR this year. Similar preoperative design, patients randomized though to 4 cycles of chemo plus or minus durvalumab anti-PD-L1. However, in this study, in the post-op setting, patients either continued durvalumab or placebo for 1 year. And the same primary endpoints, PCR and event-free survival. You'll see here, again, skews towards the stage 3 patients, predominantly. Fewer PD-L1 negative tumors here, about 33% versus 50% in Checkmate H16. And this study had a similar breakdown of more carboplatin here than cisplatin. This was the disposition. About 80% of patients got to surgery, and you'll see this in all of the neoadjuvant trials. Anything from 80 to 85% of patients actually have surgery. So on the flip side, 10 to 15% don't. And then the R0 sections were pretty high. Not all patients got through the adjuvant phase. So here only about 65% actually started adjuvant, and about 24% completed the planned course. This was the PCR difference, quite similar delta. And this is the event-free survival, 63% versus 52% at 2 years. I'd point out the 2-year event-free survival here is quite similar to the 2-year event-free survival in Checkmate H16. So it's an interesting comparison despite the 1 year of therapy, but all groups appear to derive benefit here. Toxicity, so you do see a little bit more toxicity here, perhaps because of the prolonged adjuvant phase. So you'll see grade 3-4 toxicity, 4% versus 2.5% in terms of immune toxicity. Keynote 671 was the other study which has been reported this year and published in the New England Journal of Medicine. Almost identical design to Aegean, the one I just mentioned, except with pembrolizumab here. And all patients in this study were mandated to have cisplatin-based treatment. It was also powered for event-free survival. So this study is likely to have to require less significant hazard ratio to be significant for OS. This is the breakdown of where the patients went. Again, you'll see here about 70% of patients got adjuvant treatment. So again, though we mandated, not all patients actually get to adjuvant treatment. Similar breakdown of PD-L1 positive versus PD-L1 negative here, about 34% PD-L1 negative versus 50% in Checkmate H16. These were the details you see here. Patients who had resections, pretty high. I just want to, it's actually, I think this is looking at those patients who got surgery in the study. About 15% didn't get surgery, but this is the event-free survival. Again, significant benefit for the pembro arm. 2-year rate is actually quite similar, again, 63%. And these are the different subgroups. Again, benefit for virtually all groups, more benefit if the tumor is PD-L1 positive. Pathologic response was also significantly improved with pembro. And this was one of the key slides, and this, I think, is my last slide. They looked here at those patients who didn't have a PCR. So those patients who didn't have a PCR, you could argue maybe they derived some benefit from the adjuvant pembro, but I think it's early days. But I think that's something will be looked at very closely as we go forward. So I'll stop there. We have one approval, checkmate H16, and I think it's likely we'll see approvals for these other two regimens very shortly as well.
Thank you, Patrick. That was really a wonderful review of actually where the field is at. And I think with that actually kind of comes, some additional questions, which, be great to kind of dissect collectively here. So one question that, been thinking about as we compare each of these trials and kind of look at this is that the number of cycles of chemo is different. And also the type of chemo that could be allowed is different. In your practice, Patrick, how often are you using cisplatin-based chemotherapy in the neoadjuvant setting versus allowances for carboplatin? Do you see kind of strong recommendation or kind of movement in one direction versus another there?
Yeah, I think it's hard to know. If you look at checkmate H16, there wasn't a difference really. If anything, the carboplatin arm did somewhat better, or the carboplatin group did better. However, one of the arguments for why Aegean, perhaps the results overall were a bit less impressive than Keynote 671. One of the arguments put forward was maybe that there was much more carbo use. The majority of patients got carbo in Aegean versus all of the patients having cisplatin in Keynote 671. I'm not sure what that means. It's hard to know. In my personal practice, I kind of look at the patient and see, is the patient eligible for cisplatin, or is there any reason at all I can find not to give them cisplatin? If there's no reason, then we end up generally offering them cisplatin. We're probably about 50-50, I would say, 50% cisplatin, 50% carbo at this point. And I think that's probably representative of our group as a whole, about 50-50 between the two. What's your approach, Adam? Do you think? Do you tend to do cis or carbo or?
I think your comments about, really just taking the patient individually is important. I think younger patients, those with better performance statuses, those patients actually generally are ones that I may prioritize for a cisplatin-based approach. But unfortunately, many patients that I see are older age patients, may have issues with cytopenia kind of through therapy. I've had circumstances where even when we started with cisplatin, we've had to convert to carboplatin over time. And actually, I may ask Dr. Boyes, in your circumstance over here, as a surgeon, by if a patient is recommended to start with chemo IO, neoadjuvant approach, but the patient is struggling with chemotherapy. Let's just say, kind of we're having issues with cytopenia or things like this. What is going through your mind in that regard? And actually, kind of, are there circumstances where you see it better to kind of just prioritize taking the patient to surgery? And what circumstances kind of do you, think through that recommendation there, or kind of thinking, about how you adapt your surgical plan?
Yeah, I think the cytopenias are one side of it. I think most of the patients recover in a place, and like in the checkmate study, I think they tried to do surgery around 4 to 6 weeks or so after the completion of therapy. So if they can complete it, that's obviously ideal. But if they're really getting in a place where they can struggle, then having them recover if they're still a surgical candidate, which I think most are, and their numbers can recover, then certainly we can move the surgery timeline up. Depending on staging, and probably get a short interval scan to make sure there's not some, they're not blowing through the therapy. I think from the other cases, we like our other guys, some of the endocrine disorders. I've seen that also with some of the esophageal cancers, like with some of these immunotherapy. Sometimes it's the endocrine disorders, the thyroid or even pituitary issues that actually seem to be more of a hindrance getting back on track to surgery than some of the like typical, cytopenias and things.
No, thank you for sharing that, actually. And I think it's wonderful to hear, your perspective on that. Patrick, from your perspective, actually at Hopkins, how are you approaching, and how's your group kind of thinking this through? If patients have endocrinopathies or some other issue that requires an intervention, I think, Dr. Boyes and myself, we had a patient actually where, um, developed hyperthyroidism, and actually kind of that affected surgical timeline, and needed interventions because of other issues. How, how as a group do you think through management of an AE that may happen and how that affects the surgical timeline?
Yeah, I think it takes a fair amount of coordination, especially as you come up to the date, to the planned date of surgery. Yeah, like yourself, we've had one patient, I think, who had thyroiditis, which occurred relatively shortly after the third cycle. And I'm not sure it delayed the surgery, but it did. Like we were aware of it, and we had endocrine input. And then we had another patient who developed pneumonitis just a week before the surgery. So she came in for the pre-op and she was hypoxic. So we ended up deferring the surgery there for a number of weeks. And she did fine in the end. She had the surgery maybe at week 10 after her last cycle, and she did well. But I think it does involve a lot of coordination with the surgeon. And I usually try when I give the patient the first cycle, I try and give the surgeon a rough heads up as to when they would be ready for surgery. And as Dr. Boyes said, normally I recommend anything from about 2.5 to 6 weeks after the last cycle of chemo. So I factor that forward. And if they're a younger patient, they're relatively unlikely to be delayed. So they're probably much okay. But if it's an older patient, as you said, Hatim, where they're going to have cytopenias or they're going to have some issues, then there is the chance of delay. Ironically, on the study, we didn't see most of those delays in Checkmate H16 were actually related to because it was an international study, it was related to kind of availability of OR space, patients wanting to defer surgery kind of around holidays and that sort of thing. So I think it was only about 30% of them were actually delays due to actual toxicities. The majority were not toxicity related, which I think is it's an interesting point. But yeah, I think it's an important that communication is very important after the tumor board or wherever a decision is made to do neoadjuvant.
No, and I definitely echo that. Actually, I will say, I've been really surprised with how many patients are able to get through neoadjuvant therapy, seamlessly, actually, kind of obviously kind of with, the appropriate medical management is needed. But I think that as a whole, it's really a rare circumstance that people have delays. I would definitely echo that, that in my practice as well. Josh, actually from a surgical perspective, I think one thing that comes up a lot in our discussions is, how we think through resectability. And if you don't mind just providing us a quick primer on how you approach patients with, stage 3 disease, and particularly, kind of how you evaluate what constitutes a resectable patient versus an unresectable patient. When you're seeing people in the clinic, and we discuss these options.
Yeah. So, 3 can be a very heterogeneous group. Certainly, I think the clear non-resectable ones are your 3Bs, where they got a contralateral node. But then, there are some 3Bs that, are like a T4N2, which I believe those were also included in the Aegean study. And so, it comes down to similar principles. So ideally, you can do a lobe if it's a 3. We do know that post neoadjuvant, based on some older data, if you can do a lobe and resect the tumor post neoadjuvant, they do significantly better and improve survival. When you add on, say, like a pneumonectomy, though, their overall survival, it's almost like sometimes another disease. And so for a young patient, I would think, be a little more aggressive. But if someone had like borderline lung function, and you're thinking along the lines of pneumonectomy for a stage 3, I think you got to really have a good reason for that, and some really like think through it from a surgical perspective. Um, other than that, T1 and 2, 3A, I think that's a straightforward um, indication, T2 and 2. And then sometimes if you get into like the bulky N2, say a station 4 and 7, number one, you really want to make sure you clinically stage them well and look for any distant or contralateral disease. But even in those cases, if they're a good surgical candidate and you can do a lobe and clear the disease at the end of the therapy, then I think that's a reasonable shot. I think that covers most of the threes. Dr. Forde touched a little bit kind of on those N0 patients, but I think if you have that T4N0 3A, I think that's reasonable to still give them, upfront neoadjuvant. I know at some institutions they may not feel as strongly about giving neoadjuvant for N0 disease, but I think that's a reasonable one if you can get it down to, say, a lobe from a bilobe, or parenchymal sparing surgery.
It's really great. Thank you so much actually for providing that quick primer, for us here. Patrick and at Hopkins, you know, um, Dr. Boyce had mentioned kind of this concept of in some institutes, nodal disease is one that really kind of is prioritized for neoadjuvant approaches. At Hopkins, if a patient has, say, a T4N0, how are those patients treated? Is there any difference across selection for neoadjuvant approaches?
Yeah, I think we've definitely seen a migration towards reconsidering surgery for N2 involvement. I wouldn't say that there's been a huge change on the T3 or the T4 disease. Those I think are largely, depending on the technical resectability and what involved chest wall or spinal resections and things like that, But the N2 disease, I have noticed our surgeons have been more keen to take on those cases. And we also, I didn't present it, but we had the Nadim-2 study was published in the New England Journal over the summer, which really focused on stage 2, 3A and B. So they had about, I think it was close to 50-50, 3A and 3B, and they had remarkable outcomes. Now it was a randomized phase 2. But I think if those results are replicated in 3B, then I think it kind of it raises the question of, do we push the boundary of surgery a little bit further even? Now again, in that study and in all of the trials, the surgeon up front had to deem the patient to have a resectable tumor. But I think the definition of resectability, there's been various efforts to define resectability, but it's very kind of institution and individual dependent and patient dependent as well, that it's quite difficult. There was a recent effort presented at World Lung from Europe, from the RTC, but it was really more of a stage dependent thing. It wasn't dependent. So they were saying stage 3A N2 single station was resectable, but not multi-station. Even though in Nadim there were a lot of multi-station, N2, I think two-thirds were multi-station. So I think just in lung cancer in particular, it's quite difficult to define resectable and have it spread across a whole to set one definition, and I think it's really dependent on the MDT and the group coming up with a consensus as to what they're comfortable with and what the surgeons are comfortable with,
I think that's a wonderful point, actually, and perhaps actually a very important point that, the local expertise within that practice may also lead to variable interpretations of resectability. And I think that is important kind of when we think through which patients, are being discussed in a multidisciplinary setting. So I think that's, it's a key point. Patrick, sorry to kind of keep asking you questions on these points, but really it's a great opportunity for us to kind of hear about your experience here. Is obviously there's been a lot of movements around targeted therapy and specifically targeted therapy in the earlier stages of cancer. now with the ADORA clinical trial showing overall survival. And I'll be presenting a little bit about that later. Um, are you doing molecular testing early upfront? And when are you getting these molecular results? And are they influencing which patients you select for neoadjuvant treatments versus not?
Yeah, we're definitely trying. So we have kind of reorganized. We spent many years trying to move towards multiple multi-gene panels, and now we're trying to select out those patients where we want a more rapid result. We started using BioCartis for a little while, but it didn't work out very well. So we've gone back to a single gene PCR for EGFR. And we actually have a trial for KRAS neoadjuvant as well. So we do both of those on non-squamous tumors. And the molecular pathology lab have told us they'll do it kind of quickly. So I think we're getting it back in about 7 days. And then the ALK, we've been depending mostly on either the stain or FISH, which is pretty quick. Now, obviously, we're the Alina trial. I keep mixing it up with the restaurant in Chicago called Alinea, but the Alina is being presented at ESMO, which is adjuvant alectinib. So I think that's going to be another key, because we don't necessarily want to have those patients treated preoperatively with chemo IO when they should probably be getting adjuvant therapy. So I think it is important to test. So we try and get PD-L1, EGFR, and ALK as quickly as possible. And that's kind of, we have our MDT coordinator have that as a kind of a standard, and she contacts the pathologist to try and get it expedited. I've had 1 or 2 patients where it's been really difficult, and we've ended up depending on a liquid biopsy, which isn't ideal, but it's just they've had multiple biopsies and we haven't gotten tissue. So we have a diagnosis, but not enough for NGS. Just one other point, I think, on the larger tumors, I do think some of those tumors, the local control with radiation is not great, so in some cases for T4 tumors, surgery can be helpful for local control. And especially if it's a squamous tumor that's involving kind of the bronchus or pushing into structures, you can get a lot of like fistulas and different problems with radiation, I find. So those tumors, I think, if anything, you might prefer to have them resected, but it's again, it's very operator dependent, I think.
Really important points. And it's great to know.
What's your
actually
approach at the moment, Hatim, with the
Yeah.
EGFR and ALK at your institution? Are you?
So that's a great question. So, from our perspective, we do try to get the results as quickly as we can. I think, even among the vendors that we use, it still takes about at least a week to week and a half to get the results. One of the things is that I think using a system that can provide results faster than that, and it sounds like a PCR-based system, that you're referencing, may actually provide faster results to make these decisions. But at least my thinking is that if we find an EGFR mutation, starting with neoadjuvant chemo IO based on, say checkmate 816 or such, would not be an ideal approach, and I think the ADORA clinical trial looked at surgical specimens as well as diagnostic biopsies. But I think that, it may be optimal to kind of really focus on the diagnostic biopsy to get the results as soon as possible to be able to inform, decisions in the future. And the surgical specimen obviously has more sample and more opportunity to yield results in situations of inadequacy. So that's the next opportunity that one would have with a negative result. But I think as a whole, in our practice, we're trying to get the diagnostic biopsies focused upon, we're trying to get broader testing. We've had some difficulties getting broader next generation sequencing covered and reimbursed. It'll be curious to see what the Alina clinical trial shows, and if there is data presented for PFS, but also kind of some signals around OS too. Seeing the OS signal, I think, will take a lot of time in that space. And I'm not sure that we're going to get as much of a meaningful OS readout, but let's see what the data shows to kind of provide us some clues there. I think, other questions that come up is, around other targets, like really great. And I did see a notice actually for your trial, your trial being done at Hopkins, looking at neoadjuvant um, KRAS G12C inhibition, to see how that may also influence outcomes. We'll see how that looks, but really curious about that. I believe that is G12C plus PD-1
Yeah,
neoadjuvant.
yeah,
Is that correct?
yeah.
Yeah.
So that's a study that Kristen Marone, one of my colleagues, is leading, but it's there's one arm of adagrasib alone, followed by surgery and then adjuvant therapy, and then the other arm is adagrasib plus Nivo prior to surgery, with the intention then in the post-op phase that you would have standard chemo followed by Atezo or Pembro or whatever appropriate adjuvant therapy. So that study's accruing, and it's I think we have it open at a couple of sites. The plan is to have it open at 15 sites, I think, overall. Part of the LCMC4, the kind of multi-center neoadjuvant trial that they're running, being run out of Sloan Kettering, I think.
That's fantastic. Congratulations, as a whole to your group actually for launching that. It'll be curious also to see the biology there among the resected specimens around which patients actually have from a biological perspective had better responses and what does that mean about the tumors.
Yeah, no, I think that it's a bit of a challenge with the current generation of KRAS inhibitors, because particularly with sotorasib, it hasn't interfaced very well with immunotherapy. So it's been trying to integrate those agents kind of into disease, which is also immune responsive,
Dr. Boyes, I may ask you this question actually now, hearing about all of this quote unquote heterogeneity about how the first line neoadjuvant space is being tested and kind of trials in this space and things like that. How do you view a field actually where there could be more heterogeneity in how specific patients are treated neoadjuvantly? Do you feel like that's going to influence some of your decision making? If we integrate, say, targeted options earlier, as some of these targeted options can have higher response rates, and what that may mean.
Yeah, I think from a surgical perspective, I certainly foresee the field going this way. At this point, based on the AEs of each one of these, it doesn't appear that any one of them would significantly prevent, as we've shown across multiple studies, from people not being able to get surgery on the back end. And so I suspect that will continue to be the case, and probably 10, 20 years down the road, they'll even be better and better with fewer adverse effects. And so, I think it's all good, and I don't foresee it making harder, and potentially even easier, as we showed in the Checkmate 816, more lobectomies, more minimally invasive surgery. And so I think it's definitely still heading the right direction.
Do you think the field may move into a situation where, under cases that at the time are not, or are, quote unquote, borderline resectable, these interventions will change a broader surgical thinking to kind of, think through the malleableness of that definition, moving from, just clearly resectable versus non-resectable to kind of this intensity of borderline resectable. Do you think that'll be more pervasive? And are you hearing that at surgical meetings?
Yeah, it gets a little tricky. I know here we've kind of had that discussion a little bit, and it's like for us, right? Like if they're not resectable, then they're going to go down the neoadjuvant chemo followed by durvalumab road, and radiation plays a role there. And so at least from our radiation colleagues, it's like, don't use the neoadjuvant chemo IO to try and downstage them to make them resectable. And that's kind of been an ongoing discussion. I certainly think, looking at our complete pathologic response rates, I think it's on the table for for continued discussion. And I think at this point, it's got to be a case-by-case basis. If it's one thing, if it's like, okay, are we trying to go from a pneumonectomy to a lobe, that might be a bit of a stretch. But if you're trying to go from something that crosses the fissure a little bit, and you can go from a bilobectomy to a lobe with a wedge, that's certainly reasonable. And again, it's kind of give and take. Is this like a borderline resectability based on patient fitness, or is it a tumor issue? And certainly, I think each one at this point needs to be taken on a case-by-case basis. I certainly think we're going to head that way, but it gets a little trickier.
It's great to hear what's being discussed at surgical meetings, about that concept. Do you feel among your peers and other colleagues in the surgery, realm, that there's more embracement of this borderline resectable component?
I think so.
Yeah.
I think in general.
Mhm. No, it's great to hear. Lastly, before we move from the neoadjuvant approach, Patrick, I was very intrigued actually, by seeing the ctDNA clearance, integrated into the Checkmate 816. I think this builds on work that you and Dr. Ignasto kind of published actually in Clinical Cancer Research, looking at the clearance of ctDNA as being a possible predictive marker as well. It's interesting. We here at UCSD, and Kevin Liu, who's on the call also is one of our students, has really pulled together some of our patients getting neoadjuvant osimertinib, which there's been certain indications that they have received that, for based on their clinical circumstance and such. And we saw actually similar issues around clearance of the ctDNA. How do you feel that that's going to evolve? Do you feel like ctDNA clearance as a metric in collaboration or kind of in, association with pathological response? Like, do you feel that's going to be a metric that gets moved forward?
Well, I think, yeah, Hatim, I think as we get approvals for these perioperative regimens, the pre and post regimens, I think the question that will arise is, should patients get that adjuvant year of treatment, which adds a little bit more in terms of toxicity and also kind of time toxicity and financial toxicity for patients. So I think it would be very helpful to have an additional metric in addition to PCR that you could send off, say, kind of an MRD assay and see if there's any residual disease. I think one of the challenges so far is that it's been difficult in practice to actually do that. The Mermaid trials, which were these two studies run by AstraZeneca looking at tumor-informed kind of MRD assessment. So my understanding is they closed early due mainly for practical concerns. They were getting much lower rates of detection than they had expected. I think it was about 12%, and they were expecting about 20-25%. And they were also having just difficulties because it was a tumor-informed test in getting the tumor samples to be sequenced in a timely manner, which you would think it would be easy, but it's just getting things from pathology in a particular hospital to be sent to a sequencing lab and get those results back and create the panel, So I think as the technology evolves and it becomes more straightforward and perhaps more widely available as well at individual centers, I think so it could be a very useful assay. And I would hope it would add, because I'm hesitant at the moment to expose patients to a year of adjuvant therapy if we have cured some of them with neoadjuvant only, and I think having more data on that would be very helpful. The 77T trial, I should mention, is also being presented at ESMO, which is preoperative chemo-nivo followed by postoperative nivo, and I think it'll be a cross-trial comparison, but it'll give us some idea as to what that year of adjuvant therapy might add,
Yeah, I mean, especially if it's compared against Checkmate 816.
Mm-hmm. Yeah, I think it'll be useful.
Mm-hmm. Well, thank you. This has been really a great discussion. What I wanted to do actually in the next, just a few minutes that we had is wanted to present some of the information that we have about the adjuvant space. And again, we have FDA approvals for pembrolizumab and nivolumab as adjuvant immune therapy. We also have FDA approval for osimertinib based on the ADORA clinical trial. So I'm going to present over here kind of data that was presented at the ASCO 2023 meeting. And this particularly is the overall survival analysis from the ADORA clinical trial, which looked at patients with resected EGFR mutant stage 1B to 3A non-small cell lung cancer. So I think some key points here, and this is great segue based on our previous discussion about when is molecular testing happening for patients in the early stage? How can it inform the right decision making? At least in our practice at UCSD, we're trying to do molecular testing as early as possible to help really kind of understand which direction patients should go into, realizing that the FDA approval for osimertinib is as an adjuvant therapy. There have been some clinical trials looking at neoadjuvant osimertinib, and there's some ongoing in combination with chemotherapy. I think one of the sobering realities with neoadjuvant osimertinib, as what was presented at ASCO 2023, is that the complete pathological response and the major pathological response is lower than immune therapy options in the respective populations. And so ongoing studies are looking at chemotherapy plus osimertinib in the neoadjuvant setting to try to better establish what a pathological response would be as neoadjuvant approach. So the ADORA clinical trial looked at patients with stage 1B, 2, 3A non-small cell lung cancer, and looked at with or without adjuvant chemotherapy. Some important characteristics are the patients had CNS imaging prior to randomization, and patients were included if they had exon 19 deletion or L858R mutations. There was stratification by stage, the type of EGFR mutation, as well as race. Patients were randomized in a 1-to-1 way between osimertinib and placebo. The planned treatment duration was 3 years, and treatment was continued until disease recurrence, treatment completion, or any one of discontinuation criteria met. Primary endpoint was DFS in the stage 2 and 3A patients, and some key secondary endpoints were DFS in the overall population, inclusive of stage 1B, the landmark DFS rates, OS, as well as safety and health-related quality of life measures. So here is some of the DFS analysis, and what we can see is that the primary DFS analysis was published in the New England Journal in October of 2020, in fact presented at ASCO plenary session in 2020, showed a hazard ratio of 0.2. With osimertinib, the DFS was not reached at that time compared to placebo at 27.5 months. More recently, this year, published in January in the JCO, was an updated DFS analysis in which we saw the hazard ratio still persistent in the same range, but in this case, 0.27. The median DFS was 65.8 months compared to 28.1 months. So here's just a slide which speaks about the patients who were included. We can see that there was pretty equal distribution across stage of 1B, 2, and 3A. And interestingly, about 60% of patients received adjuvant chemotherapy in each of the subgroups. Really speaks to this point too, that there's substantial numbers of patients who are not receiving adjuvant chemo. And it may actually, just ask you, Patrick, actually this in your practice, would you say that these numbers are pretty true to practice for people getting adjuvant therapy? Is about 60-40? Is that kind of what you see in your practice there?
Yeah, I would think so. There was some nice data from the Alchemist trial, which was the adjuvant trial run by the NCI, where theoretically every patient was eligible for adjuvant chemo. But in that study, they published the initial data last year, and it suggested only 57% actually got at least one cycle of chemo. So I think there's still kind of an element of, though there's a survival benefit from chemo of 5% at 5 years, sometimes the way oncologists present it to patients and also the way patients perceive it leads to some of them deciding not to do chemo, you know. I would say it's higher at our institution specifically, probably about 80%, I would say, get some form of adjuvant chemo if it's indicated.
It's great to hear that point. So here is the overall survival data. So again, this was presented at ASCO 2023. You can see is the overall OS hazard ratio was 0.49. And really at 5 years, 85% of patients alive in the and this is again stage 2 and 3A disease compared to 73% receiving placebo. Here is the data inclusive of the stage 1Bs. We can see that the hazard ratio is persistent, 0.49, and at 60 months, 88% of patients alive on the osimertinib group compared to 78% with placebo. So here's the subgroup analysis across OS. We can see that most subgroups had benefit favoring osimertinib compared to placebo, and that was inclusive of those patients who received adjuvant chemotherapy, yes or no, the type of EGFR mutation. However, it is known and it was seen in the study that L858R patients perform less well than the exon 19 deletion patients. But we can see that across stage, patients had overall survival benefit receiving osimertinib compared to placebo. And here actually just shows the figures from the New England Journal paper. And I've broken this down based on stage, where we can see the hazard ratio for stage 1B, 0.44, for stage 2, 0.63, and for stage 3A, 0.37. And then represented on the right are the hazard ratios for those patients who received adjuvant chemotherapy versus those that did not. And they were both in the 0.47 to 0.49 range. So one area that's had a lot of discussion is discussions about subsequent anti-cancer therapy and how that may have influenced survival. So in the osimertinib group, we can see that patients who received subsequent anti-cancer treatment 40 so we can see that 41% received osimertinib, 37% other EGFR TKIs. And if we look at the placebo group, 43% received osimertinib and 62% received other EGFR TKIs. About 25% of patients received chemotherapy, and about between 37% and 29%, respectively, across osimertinib and placebo received radiation therapy. I may actually ask, Patrick, when you reflect on this and the subsequent therapies, do you feel like this has any impact on your perception of the benefit of overall survival for osimertinib?
Yeah, I think it's a tough one, Hatim, because I think there was a huge amount of discussion kind of online after the presentation that this was kind of tilting the table in favor of osimertinib, that patients weren't necessarily getting the standard of care when they had a relapse. And I think it's true, but I'm not sure there's a very easy way to deal with it, So when the trial was initially planned, I think the issue was that so osimertinib was not approved or available in many of the jurisdictions where the trial was being conducted, especially in Asia and Europe. So the company felt that they couldn't necessarily mandate that patients cross over and receive osimertinib. And then about 2 years ago, I think they did provide osimertinib, but it still led to a minority of patients actually getting it at relapse. And I think it's a challenge because there are different standards of care within the US even and outside the US. And if you mandate that every phase 3 trial has to be conducted in the US, then you're going to have a lot of delays and a lot of kind of difficulties in getting these trials conducted, especially in diseases which are more common in Asia in particular. So what I see, it's kind of a something which raises questions about the results. I think the magnitude of the benefit up front, I think, does still justify osimertinib here. And you could argue as well, some patients don't get it at relapse because for various reasons, they might have very bad brain metastases. They might suddenly get sick. There's always drop off. So there are some patients who are probably rescued by having that adjuvant therapy as opposed to waiting for relapse. What are your thoughts on it, Hatim?
Yeah, no, I agree with you. In my opinion, I think the magnitude of the benefit, appears to, be substantial enough to, quote unquote, deconfound this, this layer of complexity, as you mentioned. So at least in my thinking, even, um, even if there is a little bit of disproportion there in terms of the subsequent therapies, the magnitude of the benefit seems to, be substantial enough that I think, it seems like, the signal is still, present or clear. And I guess the question then is there, like, say the readout had come out saying a hazard ratio of zero point 0.6 or 0.65, would it change the field's perspective in that regard? And at least in my opinion, I don't think it really would. I think that, um, with a hazard ratio that, shows a 35% reduction in the risk of death, kind of with that, say if it did show a hazard ratio of 0.65, I don't think it would change, our perspective here. Yeah.
Oh, no, I agree. And I think one of the other questions which are going to start coming up are those patients who are at the 3-year mark, and what do we do with those patients? Because some of the data suggests you see quite a few relapses after 3 years if you stop. So it's a kind of a tough question at that point as well.
Mhm.
So I think it's going to be an ongoing discussion,
Yeah. And I think, it's curious to learn from our colleagues in breast cancer, where, there's been extensions of the adjuvant therapies over time and how that also, will get reviewed in lung cancer as well.
Mm-hmm.
Um, so just some final conclusions here is that based on the ADORA clinical trial, there has been an FDA approval. That approval was initially approved in 2020, and now we've seen final overall survival analysis. I think it raises some important points for the future, and one of those points is how the other oncogenes will be um, well, whether or not they'll follow suit here. And, it's great, Patrick, that you shared with us the initial press release for the ALINA study. We'll have to see how other inhibitors across other genes, play out. Um, but yeah, no, I think, this has been a great discussion. Dr. Boyce, I may actually ask you at this juncture, seeing that we now have systemic agents that may be applicable both as adjuvant therapies or as neoadjuvant approaches, when we, do this, how do you feel about prioritization as you think through one of the strategies, meaning neoadjuvant versus adjuvant, or kind of do you view this, how what's happening in the medical oncology space influencing your decisions?
Yeah, definitely. I mean, I think like most solid tumors, we really kind of lean more and more heavily into the neoadjuvant space. And I expect that to continue on here as well. And I think, the survival benefit will be proven out over time. And I think that's good, and so as we tease out, more of the genomics of each tumor and the nuances of it, we may find people who really benefit more from some of these directed therapies versus saying, hey, just do surgery because we know, all these other things may not work as well, and or we'll give something to them on the back end, But I think that population is going to be smaller as we get more and more information and more treatment paradigms. So I think we're definitely heading in the right direction with earlier and earlier therapy to drive our survival advantage.
Yeah. And I think one takeaway that I also, kind of have reflected on is that when we look at these survival curves, it's truly remarkable that at 5 years, this percentage of patients with stage 3A disease are alive. If we look at panel C, bottom of the left, that's approaching almost 85% of people alive with stage 3A at 5 years. Post-surgery with adjuvant therapy. So I think really, hopefully kind of a great opportunity for patients in the future.
Dr. Husain, can I make a comment or ask a question regarding this data?
No, thank you, Dr. Lashkari, please.
I just a quick question to the panel, and that is whether you use circulating tumor DNA tests either now, or do you foresee that they may be helpful in monitoring for residual disease in this setting? I think it would be interesting to explore that in future trials if that's not already being looked at.
Yeah. No, I think it's a great point, and maybe actually, Patrick, I'll let you comment on that.
Yeah, I think there's definitely a lot of interest in that, and that first effort I mentioned, the Mermaid trial for the MRD assessment, didn't necessarily work out, but I think the technology is advancing all the time, and I'm not using it necessarily in clinical practice at the moment, but there are assays available like Signatera and others where you can get an MRD assessment, and I think some of my colleagues have used them intermittently. But I would guess that maybe 5-7 years from now, I think we'll be using them much more commonly, and probably for, particularly in the early stage setting, it's a bit harder in advanced disease, if anything, because I think usually the cancer declares itself on scans relatively quickly, but I think in early stage disease, it could be very helpful.
Well, thank you. Are there any other last questions for our panel? Well, if no other last questions, I'd like to say an extra special thank you to Dr. Forde, for participating today and really kind of sharing your pearls of wisdom in the early stage space. And Dr. Boyce, thank you so much for your, wisdom here and how we work together as a multidisciplinary team, and also, try to provide as optimal medical oncology management as well as surgical management for patients. And so without further ado, Dr. Lashkari, I'll let you have the final words.
Well, I wanted to thank our panel today for this wonderful discussion. I think all of us learned quite a bit. And of course, this is like so many other topics within lung cancer, such a rapidly evolving field. Finally, I wanted to also thank our sponsor, AstraZeneca, for sponsoring tonight's discussion. We really appreciate their efforts supporting us. And our next talk will be a month from now. I'm looking at it right here, and it's going to be on October 25th. And so we appreciate all of you here, and have a wonderful evening, and good night.
Thank you.
Thank you.
Thank you, everyone. Bye-bye.
Bye.
Thank you.